Hello everyone and welcome to today's webinar, Aldosterone and Renin Measurements in the Management of Patient and Hypertension. I'm Susie Valdez of LabRoots and I will be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by DiaSorin. To learn more, visit them at diasorin.com. Now, we encourage you to participate today by submitting any questions you might have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have any trouble seeing or hearing this presentation. This webinar is educational and thus offers free continuing education credits. Please click on the continuing education window at the bottom of your screen to obtain those credits. I'd now like to welcome our presenter, Dr. Paolo Mulatero, a full professor of internal medicine at Torino University. Dr. Mulatero, welcome. You may now begin your presentation, sir.
I'm Paolo Mulatero. I am full professor of internal medicine at the University of Torino. I work in a division of internal medicine and hypertension. In this first seminar, we will discuss the application of the aldosterone Renin ratio in the management of patients with hypertension, in particular for the detection and management of primary aldosteronism. The second part will address the use of the aldosterone and renin measurement to address the therapy of patients with hypertension and also to evaluate the adherence to the therapy. We will begin with the traditional application in the management of patients with primary aldosteronism. The European Society of Hypertension and European Society of Cardiology Guidelines of 2018 finally recognized that primary aldosteronism is a frequent cause of secondary hypertension. And the Lancet Commission in 2016 identified the lack or delayed diagnosis of primary aldosteronism or in general of secondary hypertension as one of the key factors that are associated with low blood pressure control around the world. In the talk of today, I will use the last consensus of the European Society of Hypertension published in the autumn 2020 for diagnosis and management of patients with primary aldosteronism. We begin with the prevalence of this condition. The two largest studies, prospective studies of this condition that were performed respectively in the primary care patient that were seen by general practitioner and in patient referred to hypertension referral center, display a prevalence of around 5% in primary care and around 11% in patient referred to specialized center. These data were confirmed also in other populations different from Caucasian. For example, in this study from Chongqing in China, we can see that the prevalence of newly detected patients with hypertension was around 4 to 7%, confirming the data of 5% in our Italian population. Despite this evidence of a large prevalence of this condition, general practitioner in Italy and in Germany very rarely screen patients for primary aldo. You can see that when hypertension is diagnosed, only 3 to 4% of the patients have an aldosterone Renin ratio measured by their doctors. And so it's not surprising that the detection of this condition is so poor in Europe. But Americans do even worse. You can see that only 1.6% of patients with resistant hypertension are currently screened for primary aldo, and we know this population should be always screened by their doctors, and the other patient only in 0.2%. And you can see that this attitude is not changing in the last 20 years, despite so many publications on this field show the high prevalence of this condition. And we also know that primary aldosteronism is associated to an increased rate of organ damage and cardio and cerebrovascular events. And this is due to the fact that aldosterone play a role in the cardiovascular system that is at least in part independent from the effect on blood pressure level, inducing fibrosis, inflammation, endothelial dysfunction, and many other effects that in turn are responsible for an increased rate of cardiovascular events. In this meta-analysis, we show that patients with primary aldo are more prone to develop stroke, coronary artery disease, atrial fibrillation, and heart failure compared with patients with essential hypertension, and this is observed even when patients with essential hypertension are matched for blood pressure values with patients with primary aldo, indicating that the excess, for example, of stroke is due to the specific effect of aldosterone on the vessel and not due to an increase in blood pressure level. Of course, if we have an increased rate of cardiovascular event, we also have an increased rate of hypertension-mediated organ damage. We can see for left ventricular hypertrophy and microalbuminuria. But which patient should be screened for this condition? All hypertensive patients. Ideally, it would be desirable, but probably for contention of the cost, we cannot ask this to be done. We can see the population of hypertensive patients that are suggested to be screened by the consensus of the European Society of Hypertension. In particular, patients with hypertension grade 2, 3, or resistant, patient with an incidentaloma, patient with spontaneous or diuretic-induced hypokalemia, patient with a suspected familial form, and patient with atrial fibrillation not determined by a heart disease such as, for example, a valvular dysfunction. We underline the importance of studying the patient with hypokalemia because we can see that when hypokalemia is present together with hypertension, the prevalence of primary aldosteronism is almost 30%. It is more and more important when the potassium is lower. You can see here that when potassium levels are below 3 milliequivalent per liter, the prevalence of primary aldo is between 70 and 100%. So we should screen absolutely all of these patients. But we should not forget that in most cases, at presentation, patients with primary aldosteronism are normocalemic. Only 1 out of 4 of these patients are hypokalemic at presentation. So we should not request hypokalemia in all of our hypertensive patients. We said grade 2, 3, or resistant hypertension. This is because the prevalence of primary aldo increased progressively with the increase of blood pressure level, reaching 15 to 20% in patients with resistant hypertension. Atrial fibrillation is a new indication in the consensus that was not introduced in the Endocrine Society Guidelines. And this is due to this study in which primary aldo was highly prevalent in a population of patients with hypertension and atrial fibrillation, but without an underlying cardiac structural alteration. In contrast with the Endocrine Society Guidelines, the population of patients with obstructive sleep apnea was not considered at high risk for primary aldosteronism in our recent consensus. And this is due to this large study performed in Europe and in Asia, in which we observed a high prevalence of primary aldosteronism both in Caucasian and in Chinese patient. However, in most cases, the patient with primary aldo and obstructive sleep apnea would have already another indication for screening, either high blood pressure level or hypokalemia and so on. And so only one patient would have been missed with the current indication of the consensus. So we don't think that obstructive sleep apnea per se is a condition sufficient to indicate the screening in all of these patients. So which test we should perform? Everybody accepts that the best test is the measurement of the aldosterone and renin ratio. And this should be performed and measured in all the patients we suggested in the consensus. And we should choose a cutoff for positivity that is different from the cutoff that is just suggested by the Endocrine Society Guidelines. They probably refer to old studies. Several recent studies show that the best performance of the screening test is with a cutoff between 1 and 2.7. For example, here in the Renato study, we observed the highest sensitivity in this range of ARR values. Therefore, if we want to compare the old cutoff with radioimmunoassay, for example 30, when aldosterone is measured in nanogram per dl, the new cutoff should be around 2 with direct renin concentration. Of course, the aldosterone-renin ratio should be measured without interfering anti-hypertensive therapy, because we know that most of the anti-hypertensive drug could determine an alteration of the aldosterone-renin ratio. Ideally, we should perform the measurement without therapy, before beginning the therapy. But in most cases, this is not possible. And so the best drug that we should use are alpha-1 blocker, for example, doxazosine, calcium channel blocker, such as amlodipine or lercanidipine, or even not dihydropyridine like verapamil and diltiazem. Another possible drug is moxonidine. However, we could also read and understand the aldosterone-renin ratio under interfered drug, for example, ACE inhibitor and ARBs, because we know that this drug could potentially cause some false negative diagnosis. So a positive diagnosis under this drug is highly significant. Or, for example, a negative diagnosis under beta blocker that can cause a false positive diagnosis could be considered a definitive negative diagnosis. The only two classes of drugs that should never be taken are mineralcorticoid receptor antagonist and diuretic, both thiazide and loop diuretic. After a positive aldosterone-renin ratio screening test, a confirmatory exclusion test should be performed in most cases. In particular, we can avoid the confirmation test if aldosterone values are very high, there's hypokalemia, and renin level are below the detection limit. So in this patient with a phenotype that is particularly florid, we could skip the confirmatory test. In all the other, we should perform a confirmatory test because we would like to avoid invasive subtyping procedure in patients with false positive ARR. The confirmatory exclusion test accepted by the Endocrine Society and the European consensus are 4. However, in Europe, we usually use the intravenous saline laude performing seated position or the captopril challenge test. The Florinef test is almost abandoned Whereas in USA, for example, the oral saline laude test is widely diffused. In this Chinese study, it was shown that the best cutoff for the captopril test is 11 nanogram per dl of aldosterone instead of a percentage reduction of aldosterone level, and the ideal cutoff for the saline laude test is 8 nanogram per dl. And in this study performed by the Brisbane group of Michael Stowasser, we can see that they compare the performance of the aldosterone measure in LC-MS compared with the aldosterone measured by chemiluminescent method. And you can see that the highest specificity is obtained with a cutoff of 7.8 nanogram per dl and the highest sensitivity with 7.2. It is important to underline that when we perform this type of test, we should accept a gray zone, because we cannot think that everything could be black or white, but for many patients in the gray zone, we should consider the possibility of a very mild form or the possibility of low-renin essential hypertension. Let's move now to subtype diagnosis after the confirmation of the primary aldosteronism. Subtype diagnosis should comprise always a CT scan with contrast and very thin cut, followed by adrenal vein sampling in patients that are candidates for surgery. That is, patients that consider surgery a potential therapy, so they are open to this to the surgical intervention, and they don't have major contraindication to adrenal surgery. Subtype diagnosis is fundamental because we have to divide patients in those that should be treated with surgery from patients that should be treated with mineralcorticoid receptor antagonist. However, there's a small subgroup of patients that could skip adrenal vein sampling if this is not available and go directly to surgery. These are very young patients, less than 35 years old, with aldosterone level very high, more than 30, and a specific feature on the adrenal CT scan, that is a nodule on one side larger than 10 millimeters and normal adrenal gland in the contralateral side. All the others should undergo to adrenal vein sampling that is relegated to very specialized center and comprise the cannulation of both adrenal vein and the measurement of aldosterone and cortisol in all the sample. Cortisol is necessary to correct for potential error in the dilution when the blood is taken from the adrenal vein. AVS, adrenal vein sampling, is necessary because in 38% of the cases, the imaging technique is misleading compared with the final diagnosis. So in 38% of the cases, the diagnosis is different from what was suggested by the CT scanning. We can have patients that lose the possibility of having the cure by surgery because they have a bilateral lesion on CT scan and the AVS show that the disease is only in one side. We could have patients that are inappropriately operated because of a unilateral lesion, whereas the condition is bilateral, or in a small percentage of the cases we can have the operation in the wrong side. For adrenal vein sampling, we use different indices, both to demonstrate the correct cannulation of the adrenal vein and also to show that aldosterone secretion is unilateral or bilateral. I won't go into detail because this is a highly specialized evaluation. When we have the final diagnosis, we should either treat patient with mineralcorticoid receptor antagonist or perform adrenalectomy. When adrenalectomy is performed, the aldosterone and renin level should be measured to demonstrate the biochemical cure of the condition. We can see that the clinical outcome could be variable because we can have patients that are cured, patients that are improved, and a small percentage of patients that do not have a variation of high blood pressure, possibly because there's two conditions in this patient responsible for high blood pressure level, that is primary aldosteronism and essential hypertension. However, the biochemical cure should be obtained in most, if not all patients, and should be demonstrated by normalization of the aldosterone-renin ratio. If we look at the outcome after adrenalectomy, the patients that have the best performance are patients with young age and patients with low duration, shorter duration of hypertension. This underlines the importance of early detection of primary aldo, early screening of this patient before they become resistant to drug therapy. For the therapy of the patient with a bilateral disease, we say that they should be treated with a mineralcorticoid receptor antagonist. And we should measure aldosterone and renin in particular in the follow-up, because you can see that patient operated display a lower rate of cardiovascular and cerebrovascular event compared with patient with essential hypertension. Patient treated medically could be divided into two groups. One group with a very bad outcome, considerably worse than patients with essential hypertension. And these are patients in which renin levels are still suppressed. This indicates that the amount of mineralocorticoid receptor antagonists that are taken by the patient is not sufficient to block all the aldosterone effect, or the patient is not completely adherent. By contrast, there's another group of medically treated patients in which the outcome is similar to the outcome of essential hypertensive. And this is because the renin levels are no longer suppressed, indicating a correct MRA therapy. In summary, in the first part of this seminar, we discussed the application of the aldosterone-renin ratio for the diagnosis and management of primary aldosteronism. In particular, we observed that the detection of primary aldosteronism is still disappointing around the world, and most patients with hypertension should be screened using the measurement of these two hormones to detect or rule out a condition that it has been demonstrated to be frequent in all population with hypertension. In the second part of the seminar, we will discuss about new application of the aldosterone and renin measurement, in particular to address to the ideal therapy patient with essential hypertension, and also to evaluate the adherence of our patient to anti-hypertensive therapy. The use of renin measurement in patients with hypertension could help the clinician to classify patients according to other conditions responsible for high blood pressure level. For example, patients with high renin level could have renovascular hypertension, pheochromocytoma, or the very rare reninoma. Patients with low renin level and low aldosterone level could have a genetic condition such as Liddle syndrome or 11-beta hydroxylase or 17-hydroxylase deficiency. So the measurement of renin could help us in classifying the patient according to the underlying condition. John Larag, many years ago, used renin level to classify patients with hypertension according to three groups: low renin, normal renin, and high renin level. And he used this feature to address the ideal therapy to this patient. In fact, when we got a patient with essential hypertension, we are in a difficult condition to choose among so many anti-hypertensive drugs, and we don't know which is the preferable for a single patient. And we know that only around 50% of the patients respond to the first drug that is given to them. And so John Larag divided the potential therapy in two groups, V drug and R drug. V is for volume, R for resistance. So for example, V drug are diuretics and calcium channel blockers, and R drug are beta blockers, ACE inhibitor, and ARBs. So when we measure renin level, if the patient has low renin level, we should give a V drug, that is CCB or diuretics. If the renin level are normal or high, we should give an anti-R drug. So for example, ACE inhibitor or ARBs. If the patient is on target, we stop. If the patient is still hypertensive, we can measure again renin level and take a decision according to the new detected renin values. And this hypothesis has been applied to many relatively small studies. We can see that here, for example, renin level were the best predictor of blood pressure response to antihypertensive drug. Also, the renin approach was considerably better compared to the age and race approach of the NICE guideline, or to the suggestion of giving diuretics to everybody as suggested by the JNC7. In this small study, for example, the renin approach performed in terms of blood pressure reduction significantly better than the reduction of blood pressure obtained with the suggestion of a hypertension specialist. But these were a small study that were not too much accepted by the scientific community and poorly applied by clinicians. However, the Pathway 2 trial clearly demonstrated that John Larag was right. For example, you can see here that when patients are treated with losartan, if renin levels are low, the blood pressure response is poor. When renin is high, blood pressure response is much better. And the opposite is for a thiazide diuretic. So we can use renin to choose between ARBs and diuretic, for example, to hypothesize a higher blood pressure response. In the second part of the study, they also gave spironolactone. You can see that the response to spironolactone was completely different according to renin level and according to the ARR. Patients with low renin and high ARR responded much better to therapy with spironolactone. This showed clearly that not all patients are treated successfully with any type of drug. So we can choose according to renin level or according to the aldosterone-renin ratio. Another potential application is in patients that we consider candidate for renal denervation. This is a very invasive procedure that using radiofrequency ablate and destroy the nerve, the afferent sympathetic nerve, into the renal artery. We know that not all patients with hypertension respond at the same level to this invasive procedure. It has been published this year that patients with low renin, you can see here, below 0.65 nanogram per ml per hour, respond very poorly to renal denervation. By contrast, patients with normal or high renin display a much higher blood pressure response. And if we divide the patient with low renin into patient with very low renin, you can see that there's absolutely no response on the procedure. So we should perform a renin measurement before sending the patient to such an invasive procedure. Another potential indication of the aldosterone and renin measurement is to evaluate the adherence of the patient to the anti-hypertensive therapy. We know that patients suffering from different conditions display an adherence that is around 50%, and this adherence doesn't change according to the type of drug that is administered. We know that is a little bit better in secondary prevention because the patient already suffer for a cardio-cerebrovascular event. In hypertension is around 40% because it's a condition that gives no symptom in most of the cases. And this low adherence is responsible for 25% of hospital access in the elderly. So it's a very important health problem. You can see here that when a therapy is suggested to a patient, since the beginning, there's some patients that do not take the therapy, and during the time, less and less patients are adherent. And after 1 year, around half of the patients are no longer treated. You can see here in this meta-analysis that incomplete or complete not adherence is present in at least 50% of the patient. And also in this trial in patient candidate to renal denervation, so they should be patient highly motivated to take the drug, 50% of the drug were not observed in the urine of this patient by therapeutic drug monitoring. Non-adherence is associated with an increased rate of mortality and cardio and cerebrovascular event, so it's a very important task to be improved in our patient. So we decided to study if aldosterone and renin measurement could be used to evaluate the adherence of our patient with hypertension to ARBs or ACE inhibitors. We measure the aldosterone and renin ratio in basal condition and after 2 to 8 weeks after the administration of ARBs or ACE inhibitor. We also measure aldosterone renin ratio in a group of normal volunteers to evaluate the variation of these two parameters over the time. And you can see that after 2 to 8 weeks, aldosterone level went down, renin level went up, whereas in normal volunteers, the two hormones displayed a very small variation. So we could define a cutoff, and we define it as around 50%, that could identify patients that were non-adherents. So if after treatment the reduction of the aldosterone-renin ratio was less than 50%, the patient was suspected to be non-adherent to the therapy. In that case, we would suggest the measurement of the drug in plasma, serum, or urine to demonstrate the non-adherence of this patient. Another potential use is in patients taking mineralcorticoid receptor antagonist. This is the case for patients with resistant hypertension or patients with primary aldosteronism. We saw before in the other seminar that patients treated medically should be monitored to observe that renin level should be not longer be suppressed during the therapy. If renin level remain very low, this indicates that either the therapy is not sufficient or the patient is not taking the drug. You can see here that after administration of Carenon, a mineralocorticoid receptor antagonist, both in the short term, 2 weeks, and in the long term, the aldosterone-renin ratio was massively reduced, renin level increased, whereas aldosterone level remained more or less unchanged. So we can use this measurement not only at diagnosis of our patient to rule out primary aldosteronism or diagnose primary aldosteronism, to decide which therapy is ideal for these patients, so to understand which is the preferable drug to choose for the treatment, and also to evaluate adherence that is responsible for such a low success in the treatment of our patient. In this second part of the seminar, we discussed about new application of the aldosterone renin measurement. This hormone could be used to address the ideal therapy of our patient with essential hypertension and also to evaluate their adherence to drug therapy.
Thank you, Dr. Mulatero, for that informative presentation. We will now start the live Q&A portion of the webinar. And if you have any questions you want to ask, please do so now. Just click on that Ask a Question box located on the far left of your screen, and we'll answer as many questions as we have time for. So it looks like we already have some great questions coming in from our audience. Our first question: when you use Aldosterone ratio to follow up on treatment, do you take blood while patient is on the drug?
Okay, this is an important point because when a patient with primary aldosteronism is treated with mineralcorticoid receptor antagonist, we want to be sure that we block every receptor and so aldosterone is not doing any damage to our cardiovascular system. And to see that, renin should not be suppressed anymore. And so the renin level should be unsuppressed, higher than 15, for example. And we should measure renin under treatment because we want to check the effect of the treatment on renin and aldosterone.
Thank you so much. Now, Dr. Mulatero, why should I measure APR if only 5% of the patients could have a benefit?
Okay, this is a frequent question that clinicians ask to me. First, hypertension is such a diffuse condition that even just 5% of the people is an incredible number of patients. Second, hypertension is a chronic condition. So if you are an hypertensive patient of 40 or 45 years old, you will have at least 30 or 40 years of treatment. And if you got a condition that is not essential hypertension, you will be treated by a drug that is not good for you. So you will have a much lower success in controlling blood pressure level, and even you miss the possibility of being cured by adrenalectomy if you got a unilateral form of primary aldosteronism.
Thank you so much, and I want to thank our audience for these great questions coming in. Our next question: how can I interpret APR in a patient under interfering therapy if I feel it is dangerous to withdraw from those drugs?
Okay, this is a difficult question because we know that most drugs could determine changes in aldosterone and renin levels. So we should try to have some experience, and we can interpret the data even under anti-hypertensive therapy. First of all, if it's possible, we should change the therapy into drugs that are known to have less effect on aldosterone and renin measurement. For instance, alpha blocker or calcium channel blocker. If this is not possible because the patient is under beta blocker or ACE inhibitor or so on, we can take into the account the effect of these drugs. So for example, if we screen our patient under beta blocker, and the aldosterone-renin ratio is negative, is normal. So we can be sure the patient cannot have primary aldosteronism because beta blockers are known to cause some cases of false positive diagnosis. If by contrast we have a positive ratio, so a suspect primary aldo under ACE inhibitor or ARBs, we are reinforced in our suspicion because ACE inhibitor and ARBs could give some cases of false negative diagnosis. So if the test is positive, we can really think the patient can have primary aldo. So we could take into the account the result and interpret the aldosterone-renin ratio according with the effect we know the drug have on the aldosterone-renin ratio. The only drug that is really interfering and not allowing us to interpret the ratio is spironolactone, and all the other in some way we can manage.
Thank you so much. Our next question from our audience: what position should the patient have during the sample? Should they be lying or sitting or standing, and for how long?
Okay, this again is a good question, and this has been addressed by the guideline, the Endocrine Society Guideline, and the consensus of the European Society of Hypertension. In the old time, we measured the aldosterone and renin both under recumbent and standing position, and then so many interpretations could be done with this measurement. In reality, now we make things much easier. So the patient can move from home, going to the lab, and so he's going to be standing for at least 1 hour, I think, from when he gets up. And then the patient can sit just a few minutes and the blood can be taken in sitting position. It's not so strict that is 1 minute, 5 minutes, or 10 minutes. Guidelines say 5 minutes, but if the blood is taken after 2 minutes, it's not a big deal. So we need to make guideline and suggestion easy because this procedure should be performed in most of patients with hypertension. And so we cannot ask that the procedure is too complicated. Otherwise, people will be reluctant to ask for the test.
Thank you so much, Dr. Mulatero. We have one more question coming in from our audience. ARR should be measured again after a negative screening, true or not true?
Okay, this is again an important question. We can have different situations. You measure in your patient the aldosterone-renin ratio and is negative but borderline. So you can think the patient could have a very, very early stage of primary aldo. In that case, you should measure again, maybe after 1 year, 6 months, 2 years, something like that. At least after 1 year, you should measure again. Another situation is your aldosterone-renin ratio is frankly negative. The patient is treated with, for example, 1 drug or 2 drugs at low dose, as suggested by the guidelines, and the patient is okay, is controlled. After 5 or 6 years, without any significant change in his lifestyle, for example, he is not getting obese, he didn't become diabetic, or he didn't change the diet, and so on, the patient became uncontrolled. So something could have happened, and a second disease could be superimposed to the first diagnosis of essential hypertension. So maybe primary aldosteronism developed in this patient, and so you have to measure aldosterone-renin ratio again.
Dr. Mulatero, thank you so much for your time and your presentation today. Would you like to provide any final comments for our audience before we go?
Thank you for the opportunity. I think that we have to face the fact that hypertension be such a diffuse disease. We cannot accept that it's treated just empirically in 99.9% of the cases. We should rule out secondary form of hypertension because the treatment is completely different for this patient. A patient that is cured by adrenalectomy, you change his life because you avoid this person take drugs for another 30 years with side effects, with problems, with controls, and so on. Or if it's someone that should be medically treated, you give the right drug for this patient. We are in the years of precision medicine, and we accept for hypertension we give always the same drug to everybody. This is not acceptable anymore, and not only clinicians but also patients should ask the diagnosis to be done before the treatment is started.
Dr. Mulatero, I want to thank you again for your time and for your research. We'd also like to thank LabRoots and our sponsor, DiaSorin, for underwriting today's educational webcast. And before we go, I want to thank our audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. And this webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone, and bye-bye.